I would like to personally welcome you to tonight's webinar, which is entitled HIV in the Correctional Setting, Information for Primary Care Clinicians. Our featured speaker tonight is Dr. Douglas Fish. Dr. Fish is currently the head for the Division of HIV Medicine and the medical director of the AIDS Designated Center at the Albany Medical Center in Albany, New York. He is also an assistant professor of medicine in the Department of Medicine at AMC. He completed his medical education at the Ohio State University College of Medicine and did an internship in internal medicine and in infectious disease fellowship at the University of Arizona Health Sciences Center. He completed his residency at the University of Tennessee Medical Center in Knoxville. In addition to his clinical and administrative responsibilities, he has several years of clinical experience in clinical education of healthcare workers through his work in the New York, New Jersey AIDS Education and Training Center. A significant portion of Dr. Fish's clinical and education work is for correctional settings. Tonight's webinar has been approved for CE through the American Academy of Family Physicians and is approved for 1 hour. I would like to also inform you that questions and comments can be submitted to Dr. Fish throughout the presentation. Just take a few moments, look at the bottom left-hand corner of your screen. In that Q&A box, type your questions and or comments and click submit, and he will answer them as he gets to them. And in addition, there will be a question and answer session towards the end of the presentation as well. So ladies and gentlemen, with all of that said, thank you again for joining us, and let's welcome Dr. Fish.
Well, thank you very much, Ms. Jackson, and it's a pleasure to be here this evening, and thanks to all of you who've taken time out of your busy schedules to join us this evening. So I'll be speaking about HIV in the correctional setting and give you a little background as to our work in that arena. I do not have any financial or other relationships to disclose that would be relevant to tonight's educational activities. The objectives I would like to cover would be to discuss some of the epidemiology of HIV among incarcerated populations. I'll describe the distinction between jail and prison custodial settings and how their discharge planning services may differ. We'll outline some of the many challenges that HIV-infected inmates will face upon release and list some of the strategies that we as community providers who are receiving these individuals back into our practices can utilize to best ensure continuity of their care. So a little bit about who we are. We are at Albany Medical College in upstate New York, in Albany, New York. We are the HIV Correctional Regional Resource Center for the New York and New Jersey AIDS Education and Training Center, like Ms. Jackson said. Our group has been providing HIV specialty care, consultation, as well as clinical education to the New York State Department of Corrections since the early 1990s. And currently we do on average 13 to 14 specialty clinics on site at the Coxsackie Correctional Facility, which is about 30 minutes south of Albany, per month. And our area includes about 22 correctional facilities in the regions of Northeast New York, and we see over 300 encounters and individuals annually. And this is a map of New York State and the minimum, medium, and maximum security prisons. And I'll just move the arrow here to Albany County, which is this county right here. So we are in the eastern sector of New York, and the three hubs are the Great Meadow hub that we serve, as well as individuals from the northern hub, the Clinton hub, as well as the Sullivan hub. So we will see individuals for their first consultation at Coxsackie, which is in the central New York area, and then do all of their follow-up visits through telemedicine so that they don't have to make the long trip. From here to the Canadian border is about 4 hours, and then Quebec and Montreal would be right up here across the border. Just for your reference, New York City would be down here, and this is Long Island, and Buffalo out here. So this northeast region is the region that we serve. So one of the long-standing issues with corrections and who's in custody in the United States has been a significant disparity among racial and ethnic groups. And as an example, we'll take initially the national incarceration rate per 100,000 residents. And as you can see, for every 100,000 residents, there's over 400 Caucasians, over 2,200 Black individuals, and over 740 Hispanic individuals. And if we break this out to New York and New Jersey per 100,000, the same ratios exist: 170 to 190 Caucasians, 1,600 to 2,300 Blacks, and 800 Hispanic individuals. And not only are there disparities in terms of incarceration rates, there's also a disproportionate burden of both disease morbidity and mortality, including HIV infection, among these same populations. Dr. Lester Wright was the former Deputy Commissioner for the Correctional Services in the state of New York, and at a symposium in 2007, he made several observations, and one of which was that risk takers of the law may also take risks with their health, and many of them, before entering into a correctional setting, have not had many, if any, encounters really with the healthcare system. They are very often of a lower socioeconomic status and living below the poverty level. Many will have lower rates of education. I was down at Coxsackie Correctional Facility yesterday, and one of the new patients who I saw completed the 8th grade, was able to read and write, although there are quite a number who are not able to read and write. There are high rates of history of physical, sexual, and mental abuse, as well as histories of mental illness. So the larger public health implication is that they're all part of our community, and the average length of stay in a state correctional facility can be from 1 to 3 years. So by and large, most of these people are in the community and not incarcerated if you look over a prolonged period of time. And there is a cyclical nature. Some are reincarcerated and get out, but by and large, we're thinking about this as a public health community that we can reach when they are incarcerated. So some of the next few slides will share some epidemiologic characteristics and statistics from the Bureau of Justice Statistics from the federal government that give data in terms of our prisons and the kinds of diseases that these individuals have. So much of the data will be on the state or federal level. So the most recent year from which we have data is 2008, and at that time there were reported nearly 22,000 inmates in either a state or federal penitentiary who's either HIV positive or has confirmed AIDS. And this accounts for about 1.5% of the entire population in custody in a state or federal prison. In terms of states with the largest populations, Florida was number 1 that year, New York second with 3,500, and Texas third, reporting those incarcerated individuals who are HIV infected or have confirmed AIDS. The good news is that since 1999, there has been a steady decrease in the overall number of people with HIV and AIDS who are incarcerated at both the state and federal levels. Geographically, as I said, Florida, New York, and Texas share the largest burden of those living with HIV or AIDS as of 2008. And these 3 states, while they account for 24% of the total U.S. State population in custody, they account for nearly half, at 46%, of the custody population who is infected with HIV or has confirmed AIDS. So we'll go to our first polling question. And this is the following. An incarcerated female is more likely than an incarcerated male to have HIV infection. True or false? You'll have time to vote here. And okay. So looks like it's about half and half. And the correct answer is that this is a true statement. So as a proportion, a female is more likely to have HIV infection if they're incarcerated in a state system than is a male. However, in terms of total numbers, there are a greater number of men than women who are incarcerated living with HIV and AIDS in our correctional facilities nationally. And those numbers at the end of 2008, 20,000 male inmates, 1,900 female inmates who are HIV positive or have AIDS in the state or federal systems. But as a percentage, there's a higher percentage of female inmates with known HIV infection at a rate of 1.9% and 1.5% compared to the males. And this is a relationship that has been long-standing and is also mirrored in the New York State data with which I'm more familiar. If we look at the actual total numbers, of course, for women, it is much less because there are many fewer women incarcerated than there are men. So those numbers living with HIV or AIDS in Florida was over 330, followed again by New York in the same ratio, 300, and Texas was next at 249. Moving on now to those with more advanced HIV and in fact having AIDS as defined as a CD4 count less than 200 cells, or having had an AIDS-defining infection such as tuberculosis or pneumocystis, or an AIDS-defining cancer such as Kaposi sarcoma, cervical cancer, or non-Hodgkin's lymphoma. So at the end of 2008, there were an estimated 5,700 and plus individuals in our state and federal facilities with confirmed AIDS, making up about 0.5% of the inmates in the state prison system and about 1/3% of inmates in the federal system with confirmed AIDS. And these confirmed AIDS cases count for nearly 1/4 of all HIV/AIDS cases in the state and federal system. So of all those who have HIV and AIDS, about 1/4 of them have AIDS. And again, the AIDS-related deaths are also declining in the United States. If we now focus more on just mortality, and the most recent data and year for which we have data is 2007, when there were 120 inmates who died from AIDS-related causes, and that was down from 155 in 2006, and there has been a rather steady and dramatic decline since 1996 when we developed the highly active antiretroviral therapy, the advent of protease inhibitors or non-nucleoside reverse transcriptase inhibitors that were added to our armamentarium to treat HIV infection. Of those 120 AIDS-related deaths in 2007, 112 were males, 8 were females. Florida reported, again, the largest number of AIDS-related deaths, followed by New York, followed by Texas. This looks more graphically at the numbers, two series of databases. One is the National Prisoner Statistics Database, the NPS-1, that you see, and this dates back to around 1995. And as you can see, starting in 1996 or thereabouts, there was a fairly rapid decline here in AIDS-related mortality, coinciding with the advent of these improved therapies, what we call the HART, or highly active antiretroviral therapy era. In 2001, an additional reporting mechanism, deaths in custody reporting program, also started reporting AIDS-related mortality, and it continues to decline, although the slope of the decline is less. This is death in the federal penitentiary system, and we will look at 2 years, first at number of deaths, and then we'll look at the rate per 100,000. So what we see here is in 2008 and 2007, in the federal systems, there were more deaths from non-AIDS causes, over 300 deaths from non-AIDS causes, 10 to 13 deaths among AIDS-related causes. And if we look at the rate per 100,000, it is 5 or 6 per 100,000 AIDS-related deaths, and this is similar to rates of homicide and less than rates of suicide in the federal system in 2007-2008. The next few slides, and you'll see a couple like this with this graphics, are from New York State seroprevalence data. So what is done is when people are arrested, they go to their local city jails, and in the case of New York City, this is Rikers Island, which is about 10 separate jails on Rikers Island on the East River. Each facility has about 1,000 inmates. Their total custody population is about 10,000. If they get sentenced to a state sentence and have a longer incarceration, then they will go first to a reception center that's upstate. And so when they have their initial medical intake, have laboratory testing drawn, they have been doing blinded seroprevalence HIV testing since 1988. And so when labs are drawn, an additional tube is drawn for HIV testing. This is de-identified and not linked back to the patient. It is only for surveillance purposes so that we get a good estimate of those coming into our system with HIV infection. And the positive ELISAs are then confirmed with the Western blot. So in blue on the graphic, what you see, these are the males who are represented, and in red are the females. And the rates of HIV and AIDS in 1988 were about 18% of the men, and 19 to 20% of the females were infected with HIV infection. So you see that there was this similar proportionality of more females than males proportionally. Over time, this trend has decreased, and the rate has fallen to less than 5% to around 3% in 2007 for the men, and closer to about 10% for the women. So the slope of the decline has been greater for the men than for the women. This is data then obtained by self-report in terms of trends of injection drug use. One of the reasons we think that this decrease has happened has been the availability of clean needles. We do not have in most of our cities syringe access or syringe exchange programs, but they can have access to clean needles. And so this is self-report by the incoming individuals and inmates of injection drug use, and in 1988 for the men it was 28%, for the women it was 29%, and it has fallen by 2005 to 10 to 11% for both groups. And this accounts for, at least in part, the rates of decreased HIV that we're seeing in the incoming populations in more recent years. This slide is graphics also from New York State that's looking at the HIV-related death rate in the New York State Department of Corrections. And this is a rate per 10,000, not per 100,000. But again, in the early 90s, many of our patients were dying. Rates were over 40 at one point per 10,000, and that has dropped, as you can see, by 2005 to less than 5 per 10,000 individuals dying from AIDS or HIV-related deaths while incarcerated. So this leads to our second polling question, and that is the following. Hepatitis C is more prevalent than is HIV infection in correctional settings. True or false? Okay, very good. Nearly all of you have gotten the correct answer. This is a true statement. It really mirrors what we see in the general population. So the CDC estimates that about 1.1 million people in the United States are infected with HIV. About 20%, it is estimated, out of that 1.1 million are not aware and are not in care, have not been diagnosed yet with their HIV infection. So incarceration is a time for offering testing and for patients to get diagnosed and getting into care. Whereas with hepatitis C, the estimates are quite much higher. 3 to 4 million people are thought to be infected with hepatitis C in the United States. In 2000, in New York State, as an example, the Department of Corrections and the New York State Department of Health also added hepatitis C antibody testing to their HIV seroprevalence data. So again, de-identified surveillance testing for incoming inmates at some of the reception sites within the state. And there are 3 or 4 reception sites out of our 70 correctional facilities in the state. And the males are in gray, the females are in pink. And in 2000, the rates were about 13% of the men, 23% of the women coming in were co-infected or hepatitis C antibody positive. And there has been some decline in this 7-year time period, down to 11% for the men, 15 to 16% for the females, although the decline has not been nearly as dramatic as we saw for HIV infection. And remember that the rates of HIV in the year 2000 for the men was about 5% and was about 14% for the females. So as we talk about caring for these individuals who are incarcerated, There are many models of care. In New York State, the care is decentralized across our 70 correctional facilities. There can be individuals with HIV infection in all of those facilities. They all have access to specialty HIV care via infectious disease specialists, and their primary ordering physicians, the one who actually write the orders and write for their meds, are at each of their respective correctional facilities, done by the physicians and nurse practitioners and physician assistants at those facilities. That is our model in New York State. In New Jersey, or in Rhode Island, excuse me, for example, there's only one state prison, so everyone is in that facility. There are other states that do cohorting and have all of their HIV infected individuals in one or two of their prisons. So many of us see incarceration as a real public health opportunity. It's maybe the first time and the first opportunity that an individual has had to access medical care, to have a complete medical exam, and maybe to be offered and receiving HIV testing, hepatitis C testing, and testing for other diseases. Facilities have an opportunity to optimize their care for these individuals while they are incarcerated in this population who might otherwise be very difficult to reach. If they're out in the community actively using substances, they can be very hard to engage in care. And even in my own private practice at Albany Medical College, there are people currently in my own patient panel who are actively using drugs. And at times, I think sometimes the only thing that can save them, the only chance of saving them from themselves, is if they happen to get arrested and get into a system where they can get off of the streets and off of their drugs, because otherwise they don't have motivation to do so. And we've had a number of individuals, many over the years, who have actually been grateful for their period of incarceration to help them get clean, help them get clear heads and be successful in life and come out and be very successful citizens. Just as within community settings, the care and delivery can vary across correctional settings, between states or within states, and there is variability, and the expertise at any given facility may vary even here in New York State. It may depend on their internal staffing, it may depend on the interest of the individual clinicians that they might have an HIV infection versus many of the other diseases that they're treating in their populations in custody. I'd like to focus a little bit now on the differences between jails and prisons, and they're really substantial. So jails, all the way from your small county jail to larger city jails, such as New York City, which has a jail of 10,000, Cook County, for Chicago, the LA county jails, these have very, very large numbers of individuals. These are often locally operated. They may be operated by correctional managed care organizations as well, but they have very short-term confinement, typically less than a year, but oftentimes very much less than a year. It may be a month, it may be a week, it may just be a few days. So they face significant time constraints in terms of trying to establish their patients, their inmates, if you will, in care and to get people tested, diagnosed, and treated. They also have trouble establishing continuity and developing a discharge plan because these individuals may be released anytime, day or night, without any forewarning or planning. We've even had them be admitted to our inpatient hospital unit, and we go round in the morning and the officers are there, and you go in the afternoon back to see the patient and the officers are gone. They've gotten a court order to release the individual, and so they're free and are in our hospitals no longer incarcerated. Prisons, on the other hand, are state or federally operated, longer terms of confinement, typically 1 to 3 years on average. HIV-positive inmates who are released from prisons may be more likely to have treatment plans and discharge plans. And in New York State, they go out with what's called a comprehensive medical summary, which lists their diagnoses, their most recent laboratory studies, their medications, and their appointments. And appointments are actually made. They're sent out with 2 weeks' worth of drugs of their HIV medicines and are signed up for the New York State AIDS Drug Assistance Program, or ADAP program, and every state has such a program. Some of these programs may have waiting lists. And then they are released, and also it is known ahead of time when their release date is going to be. It's typically known many, many months ahead of time so that there can be planning. So it makes a continuity of care much more manageable. In the correctional setting, there are competing goals, and so we're balancing the correctional goals of custody, security, and control of the population with our healthcare worker goals of disease prevention, diagnosis, treatment, and management of their medical conditions. The topic that often comes up is what can we do about prevention? Certainly there's a lot of education that happens. In terms of condoms, some of them are provided in some of our larger metropolitan jails such as Rikers Island in New York City, LA County, San Francisco, Philadelphia, Washington, D.C. Facilities allow inmates, although the rules and regulations and policies around them and inmates' ability to have them it can be variable. In other facilities, condoms would be considered contraband, and in the state facilities in New York, they are not widely available, although they are available for conjugal visits and in certain special circumstances. Vermont and Mississippi, and I understand also in the country of Canada, our neighbors to the north, they do provide condoms to their incarcerated inmates. Another question that often comes up is how much HIV transmission occurs in correctional facilities. And we've not historically had a good handle on this. People will always say that it's not very much, and on the spectrum it's not a lot, but it certainly happens. And probably the best study that sheds light on this came out of the Georgia prison system in a study that followed individuals from 1988 to 2005, and they were looking to document how much transmission occurred. And so they documented over this time period of about 17 years, 88 seroconversions. So these are individuals who, when they came in, were HIV negative, and they have that documented test, although it's possible that they could have been seroconverting at the time and still had a negative antibody, later tested during their incarceration and were found to be HIV positive. And they looked at these seroconverter strains. They looked to identify HIV transmission clusters and networks, and they also studied antiviral drug resistance. And what they found was that 80% of the seroconverters who were interviewed did report having sex or injection drug use in the prison before their HIV diagnosis. However, HIV was transmitted largely through sexual networks, and it appeared that injection drug use did not play a major role in HIV transmission. There is tattooing, and tattooing may have been a risk behavior. In terms of injection drug use, certainly inmates might have underreported this use because it would be considered not legal in a facility and could get people into trouble. They also looked at these isolates of HIV, and they found 10 genetically related clusters that were identified, and 2/3 of these seroconverters in these clusters had overlapping stays within the same prison with another member of that same cluster. So that's probably the best data that we'll see in terms of HIV transmission in a incarcerated setting. Some of the common challenges with service delivery in the correctional setting includes delivering care in a setting of high security, the count, the all-important count that can happen several times in a day in a prison facility, stops all movement within a prison, so they're not brought to medical clinic or taken back out of the medical clinic during the time of the count. So policies and procedures for security are preeminent. Access to histories and medical records can be a challenge. In New York State, we have a paper record, and so if they go to another facility, are transferred, and sometimes they may have numerous facilities during their incarceration. A limited amount of that medical information travels with them, but not all of their medical history. In the state of Texas, I understand and know that they have an electronic health system, so that would be an ideal system in which to have that medical system follow the individual. There can be frequent movement between facilities. Another challenge to care for the individual is the fear of stigma. So they fear if they're diagnosed with HIV in the correctional setting, this can be a reason for them not to consent for HIV testing. If they fear that there are going to be repercussions either among their other inmate colleagues or from the correctional officers or other staff within the prison setting. And then just the continuity of care because of the movement between facilities and other issues that we've discussed. I'd like to talk a little bit about the medication policies and how individuals obtain their medications in these systems. There's two main medication distribution policies, directly observed therapy versus what we call KOP, or keep on person. So in the directly observed therapy distribution system. Inmates would come to a pill window or a pill line and are observed taking their medications, and this can be a real challenge if someone has a medication that's dosed 2 or 3 times a day. In New York State, what we have is a KOP policy, or keep on person, where the individuals are basically given their medicines a month at a time. Systems may vary. They may get them a week at a time. If they have a controlled substance or a liquid medication, they still do have to come to the window for that, and perhaps a mental health medication where they might have to come to a medical window. That may also be a disincentive for some individuals because they're not required to go to the window. They have to do this voluntarily, and there are certain times of day when they can do it and certain times when they're not allowed to do it. In terms of advantages to the keep on person system, certainly this allows the individual a greater confidentiality. It requires less staffing in terms of its administration and empowers the individual to become self-reliant. At the end of the month, they have to put in for their refill at the appropriate period of time so that they can get their next month's supply. Disadvantages may have to do with medication waste and the potential for non-adherence and patients not actually swallowing their medicines but having them and destroying them. There's less interface with the medical staff, and it can be harder to assess adherence. The prison schedule may be out of sync with their need for taking their medications with food or fluid. So if they have something that's at nighttime that requires food, like some of the HIV medications can, then this can be a challenge. Also, medications can be stolen or otherwise sold or redistributed within the facility. In terms of directly observed therapy, certainly there's less medication waste. We know when they come to the window and taking their medicines, or whether they have not come. They still might cheek their medicine, but by and large most of them are going to be taking their medicines. They have more contact with the medical staff. There's a greater opportunity for education. And there has been in the literature some favorable outcomes documented, so I will show you one of those studies on the next slide. Disadvantages, as I've alluded to earlier, if there are lockdowns or other circumstances when they're doing the count where there's not any movement within the facility, this requires more staffing to do directly observed therapy. If individuals are coming and standing in the AIDS line, if you will, they can perceive loss of confidentiality, and in fact a very real loss of their confidentiality. It doesn't teach the individual very much in the way of self-reliance. It's a rather passive system. And in fact, it might increase non-adherence for some individuals if they have to come every day or multiple times in a day, if they have a regimen that requires 2 or 3 doses in a day and they have to come to the window each time. So that can be a disincentive. The next slide shows a study that was published by Margaret Fischel at one of the retrovirus meetings. This was back from 2001. Looking at people who had directly observed therapy in the orange bars versus a self-administered therapy in the yellow bars. And at every time point out through week 88, you can see that looking at viral suppression rates on the vertical axis, that there were more individuals on the directly observed therapy line in the red here who had viral suppression rates that were higher, and by week 88 out at 90% of individuals having undetectable viral loads, compared to rates that were lower, closer to 70% in the self-administered therapy arm. So this was a plug for directly observed therapy, and yet it's really not realistic for large facilities to have everybody who's on an antiretroviral and a pain medicine and a mental health medicine to be coming to the windows, because that's all that they would get done, and they couldn't do any of the medical visits. They would just be doing med administration the entire time. Another very vulnerable time for the individual is upon release from the correctional facility. So this transition from a system of full dependence to independence can be quite a challenge. There are challenges with housing. Going back into the community, there are the risk for relapse with alcohol and substance use, and especially if they're going back into the same environment from which they came, and that activity and the environment in which they're staying, that activity of substance use is ongoing. If they have mental health conditions and have mental health medications, getting back into mental health care can be a challenge. individuals may lack appropriate social supports. And this is really, I think, one of the most key items to the success. So if there's a good family structure and solid support back at home, then the individual is much more likely to be successful on re-entry. Literacy issues may be a challenge. It is common that people cannot read or write, and often, as healthcare workers, we don't always elicit this information. It's not always known, and certainly it's not something that the individual will often volunteer because they're embarrassed and they're afraid to let people know that. Language barrier can also be a challenge if there's a primary language that's other than the language of the area and the healthcare setting in which they are accessing their care. So the next couple of slides are some case scenarios. So I'll read through the case and then we'll have a polling question, and this is about a sharing of data and information. So the names are made up, but this is a 51-year-old former heroin user with HIV infection, CD4 count of over 300, a viral load 150 copies per milliliter on the fixed dose combination of tenofovir, emtricitabine, and efavirenz. And he is re-arrested on a parole violation. The medical unit of your local community jail contacts your medical office in the late afternoon with a request for the patient's problem list and medication list. And accompanying this is a signed HIV release of medical information that accompanies the faxed request for information. So the polling question is as follows. 1, you should forward the requested information immediately. 2, wait until the morning to send the records since your medical record staff have already gone home for the day. 3, not forward the records since you can't know that the patient's signature is real. Or 4, verify with the patient's family or case manager that the patient was incarcerated before sending any information. So the polls are now open for your voting. Okay, yes, that's right. We want to forward the information as soon as we get the request. This is not something that we should let idle and linger, because until they get that list, some facilities will not actually take the individual's word. They want to see the doctor's list. They want to see that this is the medicines that they're on before they'll actually prescribe them. So this can lead to interruptions and missed doses of their antiretrovirals. So we would treat this as a medical urgency and want to get that information out. And this can be a challenge even in our own office. And sometimes people are very tentative and will want to come to the doctor. Is it okay to send these records? And we are always assuring them that it is. In the second scenario, this is a 48-year-old male with HIV infection whose last CD4 count is 170. He has an undetectable viral load, and he was released from a facility the previous afternoon and had a 4-month incarceration. This is the reverse now. He's coming out of the system, walks into your office and reports that he has been on tenofovir, emtricitabine, along with the fixed-dose combination of lopinavir-ritonavir, as well as trimethoprim sulfamethoxazole or Bactrim for pneumocystis prophylaxis. He was not given any prescriptions for his medications, though he was given his evening dose to take with him the night that he left. He was instructed to follow up with his medical provider, and he's back in your office. It's now 10 a.m., and the triage nurse in your office comes to report this to you. And I might add that some of the facilities actually, especially if they're managed by a correctional managed care organization, they actually do not allow their medical providers to write prescriptions, because they will tell these providers that your medical malpractice only covers you when you're writing prescriptions within the walls of the prison and not for out in the community. So in fact, this works against us when we're trying to ensure continuity of medications. So the polling question is the following. 1, the patient will need to make an appointment. The nurse should tell the patient that the patient would need to make an appointment for the first available so that you can ensure his continuity of care. 2, the patient will need to be seen that day, but while waiting could meet with the case manager or nurse to determine eligibility status for perhaps the AIDS Drug Assistance Program or other medical and prescription coverage. 3, the patient should report immediately to the Department of Social Services in order to get a form of insurance in place. Or 4, we should tell them that we don't accept walk-ins, that he will need to go to the emergency room if he needs urgent medication, and then give him a new patient appointment for the next available new patient slot. So polls are open. Okay, and people have voted as we've spoken here, and yes, we would need to try and work the individual in. Number 2 would really be the best response here. We need to prioritize this individual, get them in, at least get them on their medications, find out what they were released on. If we know them, we may have past medical records on them. If we don't, and they're new to our facility, we may need to bring them in and do an intake, do a formal visit, or at least do an assessment to see what their need is so that they can get their medication. So excellent job there with your answers. In terms of recommendations for the community provider, in terms of jail releasees in particular, these are the ones who are most likely to show up on your doorstep without any medications or any prescriptions and have needs. Community health systems should really be prepared to receive these individuals into our practices and consider their medications an urgent situation. If the patient lacks any discharge planning records and doesn't recall what treatment they were initiated with, we can obtain records and should try to do that as soon as possible. Sometimes it may require a phone call. This is more easily done at the local level. It is certainly much harder to get records out of a state or federal facility with a phone call, and this will usually require, at least in my experience, a written release to get those records if the individual doesn't have them with them. And I think when you're requesting the records, you want to be as specific with your requests as you can be. And if you just say all medical records, I think people are overwhelmed with that request and don't really know what to send, and you might get nothing out of that. So what I request is on the following slide. I want their diagnosis. I would like their medical problem list, their medication list, including past antiretrovirals that they might have been on, particularly if it was a longer incarceration of 5 or 10 years where they were in a state or federal facility. I would also like their HIV serologies if they have them, their last syphilis and hepatitis serologies. I think in New York State and probably across the country, we waste hundreds of thousands of dollars, I'm certain millions of dollars, on repeating these serologies. They go from one facility to another, and everyone repeats the hepatitis serologies, and they've been done in some cases a dozen times on the same individual, and all we need to do is try and get those records. I'm also interested in their most recent PPD results, as well as any immunizations they received while they are incarcerated, and then their most recent CD4 count, viral load, and importantly, resistance tests. And I like to encourage the facilities to keep all of their HIV resistance tests in one place in the binder, and that these should move with them sequentially if they go from one facility to another, or at least copies of those tests, because this is really the database, the archive of that patient's resistance history, and that can be very important if they have virologic failure, and we need to design a new antiretroviral regimen for them. And then I would like to close with another program with a related disease, and this is what I think is probably a best practice. This is the Hepatitis C Continuity Program, and this is a special program that was started 5 or 6 years ago in New York State to help ensure the continuity of care for our patients who started their hepatitis C therapy while they were incarcerated. It used to be that in the state of New York, if you had hepatitis C, you had to be incarcerated for at least 15 more months in order to allow your workup for your hepatitis C, to get started on treatment, and to complete the treatment. There was not a mechanism in place to ensure the continuity and the importance of continuing their interferon and ribavirin once they were released. And this program was started as a voluntary program, and it was a real collaboration between the New York State prison system, as well as the New York State Department of Health, the Division of Parole, the New York City Health and Hospitals Corporation, as well as community-based healthcare providers and some of the designated AIDS centers across the state. And we at Albany Medical Center participated in that. So the way that it works is that about a month before the anticipated release date, we will get a call from their discharge planner from the facility. They will be letting us know the release date, and we will set a new patient appointment up for that individual within 7 days of their release. And why within 7 days is because the interferon, pegylated interferon, is dosed weekly. And they actually ship the pegylated interferon vials, 2 doses, so 2 weeks worth, to our patient pharmacy, to our hospital pharmacy, and then we get that in our office. The individual, the inmate, is released with their ribavirin tablets, and then they keep taking those medicines, and then we come see them, or they come see us. We do their initial visit. They get their first injection, their second injections in our office, and then we will continue to see them through the completion of their therapy. And these are typically very highly motivated. Our success rate and our follow-up rate has been very high because the people who are continuing on the therapy are the people who have had viral suppression after 12 weeks and that their therapy is working. So they have a lot riding on the continued success and access to their medications. So this enables the individual to finish their treatments and to begin it before they leave the correctional facility, and it promotes referrals and collaboration with our community-based healthcare providers for continuation of the treatment. And we ensure that they have access to the medications and that insurance is in place. If they have HIV infection and so they're co-infected, then we can use the AIDS Drug Assistance Program. If they do not, then we need to get them on Medicaid or some other form of access to medication to ensure that they have access. So they're not released from the facility until those pieces are in place. This is just a flyer about the Hepatitis C Continuity Program. Colleen Flanagan works for the New York State Department of Health, and she is the Hepatitis C coordinator here in Albany, and she is a fantastic resource. And she put on an excellent one-day Hepatitis C conference where we had national speakers, and many healthcare providers across the state were at this meeting last month that was held in New York City, and there were also quite a number of correctional healthcare workers who also came to this symposium. So in conclusion, we know that the burden of infectious diseases in correctional settings is high, particularly HIV infection as well as hepatitis C. And as with community providers, the quality of care can vary across facilities, across states, but people do work very, very hard, and those healthcare workers who are in these systems are very highly dedicated and hardworking and have the individual's interest at heart. The discharge planning process can always be improved, so this is always a work in progress because that release time is a very vulnerable time for the individual. And we at the receiving end in our medical practices will need to advocate for the individuals to help enlist services so that they can get support services, get successfully back on their feet, and be successful in their re-entry. A slide here just about the AETC resources. Every state in the United States is represented by a regional AIDS education and training center. The website is listed here just for your reference, and additional references here for the Bureau of Justice Statistics, where I obtained some of those data, and I appreciate the help of Sarah Walker from our division, as well as Jimmy Barra from putting some of this together for me, as well as the website for the CDC and their correctional health program. So there's a question here. A few questions from my experience in a medical referral setting. How do you overcome trust issues with incarcerated patients? Several of my patients will refuse antiretroviral therapy due to mistrust of healthcare. They all know about Tuskegee. Do you find instances for force medicating HIV patients? And how do you handle release of undocumented inmates? Many do not start antiretroviral therapy as they know it won't be available to them upon release. Okay, these are all excellent questions. So the first one, how do I overcome trust issues? Well, one of the things I talk about, and that is a very important issue, and one, they know about Tuskegee, they also know about AZT. There's a lot of AZT phobia, and they think that AZT was a poison that was given to people with HIV, and the reality is that AZT works, but it doesn't work by itself. And when it was the first drug that we had, and the only drug that we had back in 1987, it worked for 3 to 6 months, but then failed to work, and people's disease progressed. So this was seen as drug failure when the real issue was no single drug works by itself. So I always talk about Magic Johnson, and I use him as the prototype, and I say that we have access to all of the drugs that Magic Johnson has. His viral load is undetectable, and your viral load can be undetectable too. And what we're testing for is the virus, and when they say that it's undetectable, it doesn't mean that it's gone. His HIV antibody test is still positive, but it means that his virus is suppressed, and we're controlling his HIV like we would control the blood sugar for a diabetic. So I'll work with them, try to educate, and I find Magic Johnson to be a very useful person because he's someone that they all know and has been very visible in the public. In terms of your second question, do you ever find instances for forced medicating HIV patients? And the answer to that is no. We can't treat anyone without their consent. We need them to take their medications. There have been times when, and I had a telemedicine encounter several years ago, where during the encounter it became apparent to me that the patient, not only was he refusing medicines because he was giving up and wanted to die, but that he was in an acute crisis, that he was in a decompensation, he was actively suicidal, and I kept him on the medical line. I called the facility, the nurse was there, they got the psychiatrist there, and we were able to intervene right at that time and went to the medical health unit. And I saw him more recently, and now he's back on his therapy. He's doing beautifully. His T cells are 300 to 400, and his viral load is undetectable. I'm not aware of individuals or times when we are ever forcing these medications on anybody. In New York State, we have a voluntary HIV testing, so no one is forced to test. Some states do test all individuals at entry. Some individuals or some facilities test people or offer testing on entry, during their incarceration, and upon release, which is what the recommendation is for the CDC, that it be offered, that it be voluntary, but that it be offered during these various times. But I'm not aware of situations where people are ever forced to take their medications. Similarly, if patients are not fully adherent, I don't think we should withhold medications, and sometimes that question comes up. So if I don't have a perfectly adhering patient, should I not give them the medicine and say, you know, you can't have them because you're not taking them correctly? And in general, we work to educate those individuals and work with them and problem solve. I have non-adhering patients in my community practice as well, despite our best efforts, and so I would not advocate for withholding medicines either. And then the third question was, how do you handle release of undocumented inmates? Many are fearful of starting antiretroviral therapy during their incarceration if they can't get access. Well, that is a very real problem. We are very lucky in New York State in that our ADAP program does allow undocumented people to get access to the AIDS Drug Assistance Program. These regulations and rules around the ADAP programs can vary from state to state. Every state does have an AIDS Drug Assistance Program, and people can be eligible for them, but the eligibility criteria differ from state to state. In New York State, the undocumenteds are eligible for ADAP. They are not eligible for Medicaid, as an example. So many providers, especially the larger hospital healthcare settings, us in Albany, Rochester, Syracuse, Buffalo, and in New York City, will all accept ADAP as an insurance, and so we can see these undocumenteds and keep them on their medications. For other states where they don't have this, that is a real challenge. Many of the drug companies do have patient assistance programs, but it can be a real challenge, and avoiding interruptions would be very difficult. And I don't know that there's any way we could guarantee, if your state doesn't allow these individuals on ADAP, that they could have access. So I don't know that I have the perfect answer to your question. Thank you for asking them very good questions. Are there other questions?
I don't see in the queue right now, but to the audience, feel free to type them in. We do have a few moments waiting. Thanks so much, Dr. Fish, for this insightful presentation. And while we're waiting for more questions to come in, we can just do a few announcements about upcoming events. I'm not sure if we have a pod, but next week we have a few things that are on the schedule. And I would like to say too that the 2 resources that Dr. Fish mentioned are available on the website now in the share section under general primary care, and it should be listed under links. So for those of you who are interested, I did have one request for the slides, and I do want to just encourage you to email me at sajackson@msm.edu. That's sajackson@msm for Morehouse School of Medicine.edu to request the slides. Dr. Fish has been generous and will allow the audience to have copies if you'd like. So please just request them. Well, I don't see any more questions coming in, so with that said, thank you again, Dr. Fish, for coming out tonight to share with us your expertise, and to our audience as well. To our audience, thank you for your questions and comments. I'd be remiss without saying thank you to our e-learning specialist, Mr. Quallen Hare. Definitely could not do this without you. For the announcements, next week, Tuesday, our maternal child health coffee shop will be discussing emergency contraception. On Wednesday, we have a very, very excellent presentation entitled Cultural Competency in the Community Healthcare Setting. So you guys don't want to miss that. It will span all disciplines, so please pass the word to your other colleagues of the National Health Service Corps. It'll be something there for everyone. And then on Thursday of next week, we have our primary care coffee shop, and they'll be discussing palliative care and hospice, how to have the conversation with your patients. So again, this series is made possible through a partnership as a resource to the scholars of the National Health Service Corps. Direct financial support for this webinar is made possible through a cooperative agreement between the U.S. Department of Health and Human Services, HRSA, who is the Health Resources and Services Administration, and the Bureau of Clinician Recruitment and Services. This webinar was recorded and will be stored in our on our website in the on-demand section. It should be up in about a week. An evaluation for this webinar will pop up in another window if you're using Internet Explorer, and another tab if you're using Firefox. Please complete it in its entirety in order to obtain your 1-hour CE credit through AAFP. Thank you again to our wonderful speaker, to our audience, and to our e-learning specialist, and have a great evening.